I've been in the EMS business for about 35 years, and I don't use hyperbole, but we are definitely in uncharted territory right now. All the area hospitals are at or above capacity. The ICUs are full, the emergency departments are full. Patients are being treated based upon acuity, meaning triage systems are working as best they can, but the systems are really being taxed right now. We're trying to encourage people to not call 911 unless they really need to. So if they just have flu symptoms, which is likely due to COVID, but they're not experiencing severe chest pain, they're not experiencing shortness of breath, they're able to keep down liquids, they don't have altered mental status, precarious medical conditions. The best treatment is to call your doctor or stay home, not call 911, not go to emergency department. We are doing everything we can to deal with the surge. One of our biggest challenges right now is getting our ambulances out of the emergency department. When our paramedics and EMTs transport a patient to an emergency department, there's a transfer of care that has to take place. And patients who are unstable or unable to be safely transferred to the waiting room or to a chair need an open bed in the emergency department to be transferred to, and those beds are lacking right now. So what's happening particularly during peak periods, which tend to be late afternoon, early evening, particularly during weekdays when the EMS systems and emergency departments are most crowded. The last few weeks, it's gotten to a point where we have ambulances, particularly at some of the more significantly impacted areas, waiting for several hours just to offload patients and transfer care. And obviously, if they're waiting to transfer care, they can't respond to the next 911 call, which means we may have delays getting an ambulance to an incident. We're fortunate in that we have fire companies staffed by firefighter EMTs and paramedics to respond. But in terms of if the response time for ambulances may be delayed, if our ambulances are still watching patients at the emergency department and can't get released to be sent back into the system.
Speaking of delays, can you tell me about just the wait times that people are experiencing because of, all of the crews that are so busy?
So we've had some extreme examples. We had one area hospital last week. It was Christmas week, actually, a week and a half ago, where one hospital actually had 19 ambulances all waiting to offload at the same time. So you can imagine how many hours that kept those ambulances out of service, which kept some large areas uncovered. We've had some extreme examples where we've had some of our paramedic ambulances wait up to 8 hours to transfer care. These were for COVID patients who required oxygen, so they couldn't go to the waiting room. And the hospital was literally exceeding their capacity and had no available open beds, nurses or other healthcare providers to facilitate taking care of those patients. So we are working with other stakeholders, Department of Health Services, other fire departments in the area, and of course the healthcare system and our hospital partners to come up with some mitigation strategies, because obviously we need to accomplish our mission, which is to respond to time-critical 911 calls as expeditiously as possible. And those patients who need transport to the emergency department, we want ambulances readily available to do so. And certainly having ambulances parked at emergency departments for hours on end is not sustainable and has the potential to compromise public safety.
What do you say to people who say, well, why not take patients to other hospitals a little bit further out, other counties? How does that work?
The reality is the entire region is severely impacted right now. So there's really nowhere to go. Our paramedics and EMTs can't, with few exceptions, transport outside the county, but all the surrounding counties are equally impacted. So to the south, Orange County, Ventura County, they're all experiencing the same surge right now. So this is not hyperbole. This is not overstating the situation. People really need to think twice right now. We know we're going to be encountering probably the brunt of the surge within the next few weeks. So 2 weeks post-Christmas, 2 weeks post-New Year's in terms of people gathering and traveling. And it's not just people who have known or suspected COVID. If you are sick or injured or having a heart attack or get into a traffic accident or have a stroke, your ability to get timely care through the EMS system or the emergency healthcare system may be significantly compromised. And even if the 911 system is there for you, and we're doing everything we can to make sure it is, and we're able to get you evaluated and transported as quickly as possible, there's a pretty high likelihood that because there's no open ICU beds, if you're sick enough or your family member is sick enough or severely injured to need an ICU bed, they may be kept down in the emergency department for hours or days on end, which obviously is suboptimal to being in a critical care setting. So this is not just for COVID patients or so people who think, well, I'm healthy, I'm young, I don't have any risk factors for COVID, this doesn't affect me. This can affect you when you least expect it. Also could impact your family members, your neighbors, your coworkers, your colleagues. So we all really need to do our part right now to get through this surge. I think this next 4 to 6 week period is going to be critical, where the system is being taxed like it's never been taxed before, certainly in any of our lifetimes, whether we've dealt with earthquakes or large crashes of airplane crashes and train crashes, other seasons where we had bad influenza outbreaks. We've had nothing of this severity for this duration. We're now seeing patients who are younger, who are less likely to have the usual risk factors to get severe COVID symptoms coming in with profound hypoxia, where their blood oxygen saturation levels are life-threatening. They have drastic changes on their chest x-rays. They're in severe respiratory failure. Some of the hospitals are actually running out of oxygen. So the system is really being taxed right now. People go into emergency departments without life-threatening problems, are waiting often 12 to 18 hours in the waiting room just to get seen. So we really need to do all of our parts individually and as a community to get through this, whether it's wearing masks or whether it's staying home. Only call 911 if it's a true life-threatening emergency. Use telemedicine, call your doctor, go to urgent care center, but really do our parts. I think these next 4 to 6 weeks will be really, really critical. So hopefully there'll be enough people now who will have received the vaccine that will be looking hopefully towards herd immunity by the spring. But we're really concerned now with that post-surge after the Christmas and New Year's gatherings.
Are you at the point where, you're deciding between, okay, so there's a gunshot victim and a COVID patient, who's more, who can we save? Is it to the point where you're deciding the fate of people's lives?
No, thank goodness we are not at that point. So I want people rest assured, if you are unfortunate enough to have a life-threatening medical emergency or traumatic injury, like a gunshot wound, we will have first responders, EMTs and paramedics respond in a timely manner and get you to the right facility. The challenge is the right facility may be at a longer distance than otherwise, because the closest facility may be completely closed to ambulance traffic because they have no more room. And the specialist may not be available. The operating rooms may not be available if you need that level of care. And most likely, if you need an intensive care unit bed, the ICU beds may not be available. But we are not at the point where we're not responding or treating life-threatening calls, but we're having to drive further to find an open hospital. And those hospitals are really trying to be creative in terms of their surge plan and a crisis mode to provide the best care. And the rate limiting factor is getting someone an ICU bed right now, because there really aren't any to go around. So what we're having to do is board patients who need to be in an ICU setting in the emergency department area for prolonged periods of time, which is not the same level of care as an ICU. So we're not rationing care yet to that level. I think what we're talking about now with all of our partners is patients who are unlikely to survive, whether it's from COVID or non-COVID emergencies. And it's really talking about medical futility. Do you talk about compassionate withdrawal of care and comfort care, as opposed to the mantra where we do everything we possibly can and exhaust a lot of scarce resources at the expense of patients who have a lot higher chance of survival? So we are now enacting policies with our partners at the county level, whereby if someone experiences a cardiac arrest in the field, which is not the same as a heart attack. But if someone's heart stops, we go ahead and our dispatchers provide instructions for CPR. We'll have an engine company respond with EMTs. We'll have paramedics respond on ambulance, and we do everything we can on scene to resuscitate you. But if our paramedics and EMTs cannot get your heart beating again on scene, we no longer will be transporting those patients, because we know by the literature, those patients have virtually a zero chance of survival if we don't do our job in the field to get their heart going again. We don't want to transport those patients to the emergency department, which may tip them over to provide care for patients who are viable. We're also looking at the same policy for victims of severe trauma, car accidents, shootings, stabbings, and so forth, where their heart stops. We're not going to be transporting those patients either if we can't get their hearts going again, can't get them resuscitated on scene. So again, if you're having a heart attack, you'll get a robust response. We'll take you to the nearest appropriate hospital, which may be further than you're accustomed to if the nearest appropriate hospital is full. But if someone is in an unfortunate enough situation where their heart stops and they're in cardiac arrest, we will not be transporting, with very rare exception, unless we can get them initially resuscitated in the field and regain some circulation in the field.
So when, normal times, someone's heart stops, they're a gunshot victim, you take them to the hospital, it's likely that they're just going to die there as opposed to in the field. It's very unlikely that they would, come back to life, if you will, or so it's more of just kind of procedural.
Well, yeah, I mean, I think people have to understand, there's the optics when there's a victim of a gunshot wound and they're in cardiac arrest. They have no pulse, they're not breathing. Their chance of survival is extremely, extremely low. It's less than 1%. So we're talking about patients who have very, very low chances of survival to begin with. We'll initiate resuscitation as we normally would, but we're not going to transport if we can't get the heart beating again on scene. If someone is a victim of a cardiac arrest from a medical problem, such as from a severe cardiac arrest or dysrhythmia like ventricular fibrillation, where the heart electrical rhythm goes haywire and the heart effectively stops beating, the paramedics are able to provide virtually the same level of care we provide the emergency department. And we will only now transport those victims if the paramedics can get their hearts restarted again in the field. So you're right, we want to minimize transporting patients that are truly looking at futility, because we don't want to further exhaust scarce hospital resources in terms of, we want to be able to really effectively triage and provide the most good for the most number of people. Likewise, for people who are in extended care facilities like hospice or nursing homes, and they have advanced directives for comfort care only, we're not going to transport those patients either, because it's going to tax hospitals that don't have the capacity. And also, it's not the right thing to do for those individuals that they want to be kept comfortable, and to take them to an emergency department where they can't get to a bed. They're in the hustle and bustle of a chaotic emergency department. And also, they can't see their family members because of COVID restrictions. So we're trying to balance, again, doing the most we can for the most number of people. So we still have a robust 911 system. The rate limiting factor right now is getting our EMTs and paramedic ambulances out of the hospitals to be able to transfer care expeditiously. That's our greatest challenge right now. Again, we're formulating a number of mitigation strategies. We will be next week deploying some EMTs and paramedics at the most severely impacted hospitals with cots, so they will be able to monitor patients off ambulances in the disaster tents that most hospitals have constructed in their ambulance bays outside their emergency departments, again, to get the ambulances back in the field. And we're hopeful we'll have to only deal with the brunt of this crisis for another 4 to 6 weeks, really get over the proverbial hump right now with that post-holiday surge, and then hopefully things will, really get better. But make no mistake, right now, the system has really been challenged like it's never been challenged before. And it's incumbent on all of your viewers to do their part.
So you said next week, essentially, in order to free up the ambulances, there will be somebody or a place where they can go, your EMTs and the paramedics can go take that patient, stay at the hospital while the ambulance goes off and picks up another patient, essentially.
Right. We're looking at deploying EMTs and paramedics to staff the disaster tents outside the emergency departments in the ambulance bay. So our paramedics will transfer care from the ambulance stretcher to those cots and have stationary EMTs and paramedics outside the hospitals monitor the patients and let the ambulances go back in service to be able to respond to the next 911 call. I know this has been a long haul, right? You know, it's almost a year, you know, into this pandemic. And I think the problem is some of the comments by public officials and some of the media, I think, has overhyped it. But right now, this whole region is severely impacted. And like I said, even if you're the lowest risk to get seriously ill from COVID, if you need emergency medical services through 911 or need an emergency department right now, your care may be compromised or significantly delayed. So this is not the right time to have gatherings and be traveling. It's just not. Wait another month. Hopefully we'll be in a better place.